Greetings, my name is Amr Zeki. I'm an assistant professor in the Department of Medicine, Division of Pulmonary and Critical Care Medicine. The title of my talk today is From Cholesterol to Autophagy, a search for novel therapies for the treatment of asthma. I'd like to tell you two stories today. One is related to the mevalonate cascade and the cholesterol pathway for which the statins are used to inhibit this mechanism. The second part of the story is related to a cellular mechanism called autophagy. I'll start with the statin part of the story first. As many of you know, the statin drugs are the blockbuster cholesterol-lowering drugs, and they work by lowering cholesterol, but they also have significant immunomodulatory and anti-inflammatory effects, as can be seen in this slide here in the top left-hand panel. They are very much involved in inhibiting leukocyte migration and in stabilizing endothelial cells and reducing inflammation in many different cell types. As a result, many different groups have used the statin drugs to study different inflammatory disorders to try and determine whether or not these drugs can be used as anti-inflammatory medications in other conditions. We decided to look in asthma, which is a chronic inflammatory allergic disorder that causes significant airway inflammation and symptoms of shortness of breath, wheezing, and bronchoconstriction. And this pathway, as you can see here in the bottom left-hand panel, is the mevalonate cascade, which is also known as a cholesterol biosynthesis pathway. It's specifically inhibited by simvastatin, and this is the molecular structure of the drug. And simvastatin, which is one of the statins, works by inhibiting HMG-CoA reductase, and in doing so it depletes mevalonate. Mevalonate, or mevalonic acid, is the immediate byproduct of this enzyme, which eventually leads to cholesterol. So we hypothesized that in our mouse model of asthma, which is induced by exposure to ovalbumin, which induces eosinophilic allergic airway inflammation in the mouse model, that by treating with simvastatin we could attenuate allergic inflammation. And further, we hypothesized that simvastatin would be working specifically through the HMG-CoA reductase pathway. And to test that, we had another arm where we treated with simvastatin and mevalonate together. And the prediction would be that if this is the pathway that the statin is working, then by supplementing with mevalonate, we would abrogate the protective or anti-inflammatory effect of simvastatin. And what you see here in the right-hand panel on the y-axis is the average total cells from whole lung lavage of mice, or bronchoalveolar lavage. And what you see on the x-axis is the different treatment groups. These are the air controls, these are the oval or allergic asthmatic groups. And what you can see here is in the OVA allergic control, you can see significant airway inflammation, as represented here by parabronchial airway inflammation. And the group that received simvastatin had a greater than 60% reduction in this inflammation, as you can see here. And this is the corollary H&E lung slide that shows a reduced level of inflammation around the airways. And as predicted, when we treated with simvastatin and mevalonate together, we did not see this inhibitory statin effect, i.e. it abrogated the protective effect of simvastatin, and this is also seen here. Meaning when you treat with simvastatin and mevalonate together, you prevent the protective anti-inflammatory effect of simvastatin. As an additional control, we also looked at mevalonate by itself, and it had no additional inhibitory or excitatory effect in terms of inflammation. So what this tells us is that simvastatin has an inhibitory effect in the allergic asthma model, and it does so specifically by inhibiting the production of mevalonate vis-a-vis the cholesterol biosynthesis pathway. Looking further in this model, we also looked at airway physiology, and what you can see here on the y-axis is respiratory system resistance. And what you see here on the x-axis is baseline measures as well as increasing doses of methacholine bronchial challenge. Methacholine is an agonist that causes bronchoconstriction in this model. And what this looks at is a physiologic outcome called airway hyperreactivity and airway resistance. And what you can see here, as expected, is the OVA allergic group, or the asthmatic group, had the highest airway resistance and airway hyperreactivity with increasing doses of methacholine. The group that got simvastatin had a significant inhibition in airway hyperreactivity and a lowering of airway resistance. And interestingly enough, the group that got simvastatin and mevalonate, the anti-inflammatory effect was reversed, as I showed you in the previous slide. This was not seen with respect to its effect on airway resistance, meaning, in summary, that while simvastatin did have a beneficial inhibitory effect on airway hyperreactivity, treating with mevalonate and simvastatin together did not reverse that effect. And what this indicates is that statin does have a benefit on airway hyperactivity, but its mechanism is perhaps mevalonate independent and independent of the inflammatory pathway. So this led me to look further in humans, and we currently have an ongoing randomized clinical trial looking at patients with severe asthma who will be treated in addition to inhaled corticosteroids and long-acting beta agonists, which are standard of care therapy. They will be randomized to simvastatin for 6 months in a crossover design where they will be treated with the drug for a 3-month period followed by a washout and another 3-month period. At the end of that exposure intervention, we will be performing various measures of clinical outcomes as well as biological outcomes, including airway brush biopsies, exhaled nitric oxide, measures of inflammatory biomarkers, and nasal and epithelial brush biopsies to look at biological markers, in addition to the clinical outcomes that include lung function and exacerbation rates. And we hope that this pilot study will lead to further larger clinical trials. Now, in the second part of the talk, I'd like to talk to you about autophagy. Autophagy is a conserved cellular mechanism that literally means self-eating. It is evolutionarily conserved. It's a cellular survival mechanism that is important in energy utilization, metabolism, and pathologically in inflammation, infection, cancer, and immune responses, as well as healing. And very simply, what this involves is the formation of an intracellular membrane that forms an autophagosome and later an autophagolysosome. And what it does is it encapsulates cellular debris and organelles and various cytoplasmic proteins, and in fusing with a lysosome forms an autophagolysosome, which then takes that cellular debris, breaks it down, and uses it for energy utilization. And this process is conserved in all cell types, including in yeast and in higher life forms, and is very essential for cellular survival as well as physiology. Now, what happens in disease is this pathway is co-opted, we believe, and in many different inflammatory disorders it is operational. What you see here is a study by Poon et al. Where they took airway endobronchial biopsies of patients with asthma, and compared to normal controls, what they noticed was an increase in the formation of autophagolysosomes and autolysosomes in the airway epithelial cells, as well as in this particular slide in the sub-epithelial airway fibroblasts. So we see that compared to controls, there's an increase in autophagy flux. What we did in a collaboration with the Gavami lab in the U of Manitoba was look at the asthma model in mice, and in this case using house dust mite instead of albumin, which also induces allergic eosinophilic airway inflammation. And very briefly, what we observed that in both the acute and in the chronic models, we saw an increase in autophagic activation or autophagy flux, as well as an increase in fibrosis as measured by fibronectin and collagen. And what this indicates is that there is simultaneous activation of not only inflammation, but also autophagy and fibrosis. When you look at immunohistochemical staining for LC3 beta, which is one of the central components of autophagy flux, you can see that in the airway epithelium there's increased staining, as well as in the sub-epithelial compartment, indicating that there is an increased activation of autophagy in the setting of allergic inflammation. Looking further beyond the mouse model, we were able to obtain fibroblasts from asthmatic patients as well as non-asthmatic controls and look for the similar proteins in those cell types under TGF-beta stimulation, which induces the fibrogenic response. And what we see is that in the asthmatic fibroblasts, there's a great increase in the collagen production as well as fibroblasts, and simultaneous increase in LC3 beta as observed in the mouse model. Looking further to confirm autophagy flux, you can see that there is increased formation of autophagolysosomes using transmission electron microscopy, which is the gold standard to show the presence of autophagy flux. And you can see that in the human asthmatic fibroblasts as well as normal fibroblasts with TGF-beta stimulation, there's an increase in the formation of autophagosomes as well as autophagolysosomes in both human airway fibroblasts and in human airway smooth muscle cells. So what this indicated to us is that autophagy is indeed present and active in both cell culture as well as in the asthma model and from donated airway mesenchymal cells in patients with asthma as compared to their controls. In doing so, we did several experiments using baflomycin, which is a drug known to inhibit autophagy flux, and we saw significant reductions in the formation of fibrosis. However, one of the problems in delivering this drug in terms of therapeutic innovation is how do we get it to the right cell compartment? And what you can see here is that in a normal asthmatic airway in cross-section, you can see the airway epithelium provides a significant barrier for which the sub-epithelial space includes the airway smooth muscle cells as well as the airway fibroblasts. And it is this layer that we choose to target in terms of delivering the drug payload, baflomycin. In order to circumvent this problem, we formed a collaboration with the Kit Lam laboratory, who was able to place baflomycin in a disulfide cross-link mycel nanoparticle that held the drug in stable formation. We further were then able to use a very specific peptide called LLP2A, which is an alpha-4 beta-1 integrin peptidomimetic that specifically antagonizes cells that express that integrin molecule. And as a first step, using Dr. Kit Lam's BEAT technology, he was able to show that this specific integrin will specifically bind human airway fibroblasts and not bronchial epithelial cells. So what this indicates to us that we might be able to use this approach in order to tag the baflomycin-loaded nanoparticles with this integrin molecule and directly deliver the drug in a cell-specific targeted manner. And our approach, our next step would be to do this in the animal model where we use these tagged nanoparticles that have the baflomycin payload and instill them via the intratracheal route to see if we can specifically deliver this drug to the airway mesenchyme without disrupting the airway epithelium. And in doing so, we hope to inhibit not only autophagy, but the downstream fibrotic response that results in airway thickening and airway remodeling in asthma. Very briefly, I'd like to end this talk with a few slides looking at the researches and collaborations both here at UC Davis as well as abroad. You can see here that I've used both cell culture methods, animal models, as well as human clinical trials, and I've collaborated with various different groups, both locally here at UC Davis as well as the University of Manitoba in Canada. And most recently, I've also been able to utilize the Primate Center in doing several studies looking at the development of inhaled drugs to treat asthma. And finally, the timeline of my research training and progress. As you can see, I started here as a T32 scholar and then in the K30 or MCRTP program. I was fortunate enough to receive an ATS fellowship award that then led to the CTSA KL2 or K12 award. I'm currently in the beginning of my second year of the NIH K08 award, which is supporting the clinical trial I described, as well as two other aims, basic science aims, looking at the mechanism of statins in airway epithelial cells. And I'm hoping that this will lead me to the next phase, which is an NIH R01 trial, as well as other R01 submissions to look at novel therapeutics for the treatment of severe asthma.